So good evening, friends. Welcome to this Tuesday evening class sessions from Yashoda Group of Hospitals. This has been almost 5 years plus. Every week we bring some topics of interest. And today we have one more area which has been a major killer in most of our intensive care units. So over the last maybe 3 decades or so, since I've been a medical student, the sepsis infections, multi-drug resistance, antimicrobial resistance, all this been a strong area of concerns for many of us. In spite of so much of changes, evolution in critical care, the mortality of severe septic patients or patients with sepsis and shock is remained to be as high as 30 to 40% in the best of the centers across the world. So we came along with many guidelines from 1990 to till 2026. In the last couple of months, we have received a updated guidelines from surviving sepsis campaigning, and Dr. Aditya was very kind enough to actually bring those changes, and he made it very interesting, saying he reloaded and revisited. So Dr. Aditya is our senior consultant in the Department of Critical Care Medicine in Malakpet Hospital. Welcome, Dr. Aditya, on board.
Thank you, sir.
So we have two panelists. I think Dr. Ritu also joined us. So welcome, Dr. Payal Bose. Thank you for joining us today. She has been a good friend of all of us, being very active and dynamic in the current generations, and been taking a huge part in the northeast part of the critical care medicine and the fraternity, and he bring the forefront of many academic sessions. Dr. Payal was a part of Medica earlier and has been now a part of heading the department in Siliguri Manipal Hospital. Ma'am, welcome you on board.
Thank you, sir. Thank you for the opportunity to participate in this esteemed webinar of yours.
Thank you. So, Doctor, I also request and invite Dr. Gunchan Paul. Ma'am, can you switch on your camera? So she's been the professor in Dayanand Medical College Hospital in Ludhiana. Dr. Gunchan has been a part of the new executive committee. She started at tenure. She has been in the academic front of many of our programs and webinars. So welcome, Dr. Gunchan Paul. It's
Thank
on.
you, Dr. Venkat. Good evening. I'm sorry, because of some internet issues, it is taking time.
No problem, ma'am. You can be on board with only probably
Yes.
voice. Yeah.
Yeah.
So again, a very good friend of mine, Dr. Himal Dev, has been known for his multitasking, not just critical care, but keeping the work-life balance and making all of us enjoy the part of critical care. Dr. Himal Dev, welcome you on board. And he has been the chief consultant of critical care medicine in Apollo, Sesadripuram, Bangalore. And more than that, he has been a new generation dynamic leader and an intensivist in the southern part of this country, Bangalore. Welcome you, Dr. Himal Dev.
Thank you, Dr. Venkat. Very kind words. Hoping for a good discussion.
Yes, yes. So I also invite Dr. Ritu Singh, Associate Professor of Critical Care in Indira Gandhi Institute of Medical Sciences, Patna, Bihar. Dr. Ritu Singh has been has been a dynamic new generation lead in many academic fronts. Welcome, Dr. Ritu.
Thank you, sir, and welcome all panelists also and speaker.
Thank you. Thank you for all being joining here. And I request now Dr. Aditya, the session will be something like that. Dr. Aditya will take us through the new changes in the recent surviving sepsis guideline. He will touch upon it's a huge document. So he will touch upon, and then all of us will probably take some of those interesting areas which are of our concerns, and then we take the discussion from there. Over to you, Dr. Aditya. Aditya, can you unmute yourself?
Yes, I'm just sharing my screen.
Yeah, we can see, make it full screen.
Yes, sir, I'm doing that. Yes, I hope it's full screen for everyone.
Yes, perfectly.
Yes, sir. Yes. Thank you so much, sir. And good evening to everyone, to all the panelists and everyone who has joined the webinar. So as already discussed by Venkat, sir, the surviving sepsis guidelines, the updated guidelines were recently published, and a lot of content has already been discussed. So in this webinar, we are just going to touch up a few important points, or rather statements from the guidelines, and then have a deep dive into it. So coming to sepsis, the definition has remained the same. It is life-threatening organ dysfunction due to dysregulated host response to an infection. And it's got a pretty significant global burden, and India especially shares 1/5 of it. So when we come to sepsis, it's a diagnostic dilemma. Sometimes there's a lot of uncertainty and variability in how people arrive at the diagnosis. In the current day world, if everything doesn't fit right, then the sepsis takes the usual blame for everything. Hence, the guidelines emphasized on clear-cut terminology when it comes to defining sepsis. They have defined in 4 ways. They have put up terminologies like definite sepsis, wherein the sepsis is confirmed with respect to history, clinical examination, and diagnostic testing. They have also put up terminologies like a probable and possible sepsis. It's been there. I mean, it was there in the previous guidelines, but they have emphasized it in this edition of the guidelines. Now, coming to the brief summary of the current guidelines, it's got 129 statements. The previous guidelines had 93 statements. There are 46 new statements. 64 of them had conditional recommendations, and there have been 17 strong recommendations, which I'll be displaying in the end. So we are going to go about the guidelines in brief in 8 categories. So coming to screening and early management, the important points that were discussed in the guidelines were first, they have added this recommendation, which is a pretty strong recommendation, emphasizing on quality improvement initiatives in sepsis. We all know that all of us are having a lot of quality improvement programs in our hospitals, and then we keep track of various care processes in our practice. And then when it comes to sepsis, introduction of quality improvement initiatives has proven to be beneficial in streamlining the care processes, like administering early antibiotics, drawing blood cultures, fluids, etc. There was also a suggestion for something called as a code sepsis or a sepsis huddle. We all have different codes in our hospitals, like code blue, code stroke. So what it does, it brings along a specific team to the bedside whenever the screening flags off a possible or a definitive sepsis. And then all of the team, they decide on the further course of action. So this saves time with respect to administrative antibiotics and different components of sepsis care. So this is something new that was discussed in the guideline. There was also a discussion, or rather a recommendation, about pre-hospital sepsis screening tool prior to admission, which happens in the ambulance. So how feasible it is in our setup? It's definitely feasible in some areas in our country. In the West, definitely they have a stronger EMS program. We will be discussing more about this in the panel discussion. There was a strong recommendation for using early warning scores, the NEWS 2, SIRS over QSOFA. The previous guidelines also emphasized on this, and then now it is a strong recommendation. Certain rapid host response diagnostic tests, that there was mention about a few, and there is insufficient evidence against using them to diagnose sepsis. So the emphasis was on clinical management, clinical examination. The fluid figure remains the same, but just weight-based. I mean, there was emphasis on a personalized fluid administration, wherein sometimes the patient who has a congestive cardiac failure, we may not be giving 30 ml per kg body weight of fluid. So we have to, keep on assessing the fluid status at regular intervals and then guide our fluid therapy. There was a suggestion for a weight-based administration. They have put up this table in the current guidelines, and they have also put up a statement saying that in obese individuals, they can use an adjusted body weight rather than the actual body weight. So this is something new in this guideline. There was also a discussion for giving vasopressor administration concurrently when there is unstable shock. Unstable shock as in when the vasopressor doses are increasing, there is cyanosis, altered mentation, etc. And there was also a mention about giving vasopressors by peripheral venous access. It was there the previous time, but it was mentioned as administering for a shorter duration. In this current guideline, they have not specifically mentioned about the duration of vasopressor administration through a peripheral venous access. So sometimes we start off with a low dose vasopressor, maybe go up to maybe medium dose vasopressor, and then again get successful in weaning from the vasopressor. So this does have a significance in our practice. Now there's a strong recommendation regarding the MAP targets as it was carried over from the previous guideline, but they have given a range that you can use a MAP of 65 plus or minus 5 millimeters of mercury because we cannot maintain the absolute figure of 65. So a range of plus or minus 5 is feasible. Now they have also spoken about MAP targets in geriatric individuals in age groups more than 65 millimeters of mercury. They have spoken about a MAP target of 60 to 65 millimeters of mercury. The intent for that is to prevent prolonged or a higher vasopressor dose exposure to the elderly age group. Now coming to the timing of antibiotic administration, nothing has changed from the previous guideline. So when there is a definitive or a probable sepsis, irrespective of whether the shock is present or absent, we have to give antibiotics within 1 hour. If sepsis, if it's a possible sepsis, but the shock is present, we have to again give antibiotic within 1 hour. But now here comes a challenge that if sepsis is possible, but the shock is absent, they have given a time frame of 3 hours, wherein we can reevaluate whether the patient is really septic or not, and then we can give the antibiotic. So this point we will be discussing again later. Now, there's something new that has come up in the current guideline regarding the administration of antibiotic prior to arrival to the hospital. When the transport or the entire evaluation is deemed to be more than 1 hour, then there's a recommendation, the conditional recommendation to give the antibiotic en route to the hospital in the air ambulance or in the ambulance. So this requires a very strong EMS support, which may not be feasible in many areas. Now, regarding source control, the previous guidelines spoke about the feasibility as early as possible, but they did not give an absolute figure. So in this current guideline, they have said within 6 hours. So that is something that has changed. Now, coming to empirical antibiotic therapy, there was a discussion specifically regarding the anaerobic coverage, wherein they have suggested against empirical anti-anaerobic organisms because the intention was to preserve the microbiome, and using anaerobic therapy would disturb that. So this is where we need to choose our empiric antibiotic judiciously. Antibiotics like piperacillin, tazobactam, if used, does have some anaerobic cover, and then they had suggested that maybe we can use something else other than that, and then if the other antibiotics are not effective, then maybe there is no choice for us. So this is something new in this guideline. Antifungal therapy, empirical use, they have suggested to use it on a case-to-case basis, and then empirical antifungal therapy has been discouraged. And also the use of candida fungal biomarkers guiding initiation and discontinuation of the empirical therapy also has been discouraged. Now, there's a strong recommendation regarding the prolonged infusion of beta-lactams. It was there in the previous guideline, but there's much more emphasis on the prolonged infusion. We can use a piperacillin tazobactam over 4 hours, carbapenem over 3 hours, and it has led to better results because all these antibiotics are time dependent and then more concentration above the MIs. Now, regarding de-escalation, if we have a sure shot diagnosis of sepsis and the organism, then there's a strong recommendation for de-escalation. Here, what they mean by de-escalation is narrowing down on the antibiotic and give a antibiotic which is sensitive. Coming to hemodynamic management, in this guidance, they have put up this table, which is very, very informative. It was not there in the previous guidance. So three categories that they have discussed about is a monitoring, wherein they have emphasized on lactate based and a C capillary refill time based monitoring in diagnosing sepsis, screening. And regarding fluids, the 30 milliliters per kg of fluids, preferably crystalloids, is the first choice of IV fluids to be given within 3 hours. And in crystalloids, the preference is towards the balanced crystalloids. And regarding vasoactive agents, non-adrenaline is the first choice of vasopressor. And then if the shock is worsening, there was a suggestion to add on vasopressin or epinephrine later on. Now, if the shock is still persisting, there was emphasis on reassessing again using dynamic indicators to assess the fluid responsiveness, and then see the trend of lactate and the capillary refill. There was also a suggestion for giving additional fluid if at all the patient is fluid responsive. And the vasoactive agents we have already discussed. If the patient has a cardiac dysfunction, then the suggestion was to use a dobutamine, add on dobutamine to noradrenaline, or using epinephrine alone. Now, this is something which has been revised. In the previous guidance, there was emphasis on invasive blood pressure monitoring, but now the suggestion is use either of invasive or non-invasive. The results have been the same. For low grade of shock, wherein we sometimes go away with monitoring noradrenaline, if we think that the vasopressors can be weaned in a specific amount of time by our clinical judgment, then we can go away with just a non-invasive rather than going for an invasive line. Now, regarding crystalloids, there has been an upgrade to a moderate certainty evidence. There was inclination towards balanced crystalloid solutions to that of 0.9% saline, because as we all know, 0.9% saline can increase the chloride load in our body, really leading to an acute kidney injury. Now, coming to the issue of albumin, again, there was a preference towards using crystalloids alone over crystalloids with supplemental albumin. Sometimes we do use that, but the suggestion is that to use albumin, supplemental albumin, in a certain situations when the patient has cirrhosis or the patient had already received large volume crystalloids, but we are not getting any proper response. Emphasis was made on lactate guided and also CRT guided resuscitation, wherein we see the decrement of lactate rather than aiming for complete resolution of the lactate. Now, there's something which is interesting in this guidance. There has been very insufficient evidence for the use of methylene blue and midodrine. So, speaking about midodrine, we do sometimes resort to oral midodrine whenever we see a patient to be stable, but we are unable to shift the patient out of the ICU because of the lingering low dose of vasopressor. And also regarding methylene blue, there have been panel discussions and debates in various conferences, various academic fora regarding the use of methylene blue. But in this situation, almost 68% of panel members had never used methylene blue, and only 1.6% of the panelists, whoever have voted, they have they use methylene blue in their daily practice. So at this point of time, there is no much evidence that they could put forth in guiding us. Now, coming to respiratory support, there was a mention about liberal versus conservative oxygen targets depending upon patient characteristics, which is something new now. And there was a conditional recommendation for use of HFNC in type 1 respiratory failure. This was preferred over conventional oxygen therapy. This was preferred over NIV and also alternating between HFNC and NIV. Probably because HFNC is better tolerated and the patients can have food, can talk while on HFNC. Whereas NIV sometimes can be uncomfortable and can cause PCL. But again, there was some evidence regarding some discussions regarding the use of helmet and then leading to a better outcomes. But they have not mentioned in this guidance, but there were discussions regarding this. Now, trial of awake proning, we have, seen this a lot with the SARS-CoV-2 patients, wherein awake proning was the norm in that time, and the evidence that was provided in suggesting awake proning were those patients. So they have suggested that we need to look at patients who have not got COVID. So maybe we will get more information regarding this. Now, when there is sepsis-induced hypoxemia and without ARDS, the new thing that they have suggested is to use a 6 to 8 ml per kg body weight of tidal volume. Corticosteroids, IVIG, blood purification, everything is same as the last time's guidelines. There's also a suggestion against the use of vitamin D, which has been added in this guidance. Now, regarding additional supportive therapies, they have spoken about active fluid removal. We speak about active resuscitation, wherein we given a lot of fluids, but there was no active thought on what to do with the fluid that has gone inside. That can lead to detrimental effects. And then in this guidance, they have mentioned about active fluid removal through diuresis. And if diuresis is not working out, one can resort to filtration. But how feasible it is, that we'll be discussing again in the panel. Guidance regarding nutrition, VTE prophylaxis, glycemic control, bicarbonate is same as the previous guidance. Now there have been certain new things that have come up in all these sections. In the goals of care, there was a suggestion that the clinicians may provide an opportunity for the patients who have recovered from sepsis to execute advanced medical directives, because there can be sudden deterioration or maybe a prospective deterioration, and then this execution of advanced medical directives can be helpful for their families. And there was also a talk about educating the primary care physicians about sepsis. This would help them to tackle patients who have discharged from the tertiary care setups into the rehabilitative care, and primary care physicians are the people who deal with these patients. There was also suggestions regarding offering post-critical care illness follow-up services, cognitive targeted therapy, physical rehabilitation, and mental health. So these were some of the key, or I would say, notable points in the surviving sepsis guidelines. It's a very huge document. These were some things I thought that maybe we can discuss on it. Now, before I end, I just want to put up these 17 strong recommendations, that statements that are there. So we have spoken about most of them in this talk. I have not mentioned about the blood culture before antibiotic, because we practice that, whether or not we talk about it. So that is the norm that has been following. And something about plateau pressure being 30 and using the low molecular weight heparin is something that we are following regularly. So with this, I would like to end my talk. Thank you so much.
Thank you, Aditya. Thank you for that quick and brisk presentation of such a long document. And probably we'll take questions, and that will make us more interesting. Probably I will hint towards one point, that the sepsis is categorized into possible, probable, definite sepsis, and not possibly a septic patient. That's again a new words used. They have not changed the definition of sepsis. The definition of sepsis remained to be the same, but they used, they know we don't have a way actually to pick up host response in any way. So they actually tried to say, we don't have a way to pick up the host response. It's all on the organ dysfunction way. So let us have some discussion. We have a good, eminent team members and colleagues and clinicians who actually deal these cases day in and out. And they've been a part of this sepsis management for the last decade or so. So first question to Dr. Gunchan Paul, ma'am. We have seen a rise and fall of QSOFA. Came in a big way in 2016 with Sepsis 3 guidelines. We all realized in a quick time that QSOFA may be a very good predictor of mortality, but probably likely chances that we may miss many of the early cases of sepsis if you follow the QSOFA. And old age CIRS response, 2 out of them, were too sensitive to actually pick up a case of sepsis with an infective etiology. Any sore throat will have a tachycardia, will have a fever, will fit into sepsis. So again, we went alongside the clock and back to the same point that one is too sensitive, the other was too probably predictor of a mortality. And we have come with a few more names which we use as a probably a met call response team markers like a Mio scoring, new scoring, new to scoring, all that. Most of the scores were used in most of our met calls or a rapid response team or my nursing team uses them in the wards to pick up this early warning sign of any patient. It doesn't matter is it septic or others. So what is your take, ma'am? The news too has been preferred over others, and this last 6 years, 2016 to 2026, it's been 10 years. So what do you think this change is happening?
Thank you, Dr. Venkat, for inviting me here. And you rightly said that Q SOFA has been long-standing, but then it has, we should know that no tool is an ideal tool. When we use Q SOFA, it is good for picking up patients, but then it has low sensitivity. We are going to miss many patients. So as a screening tool, yes, they have refuted it as a standalone tool. It has to be used along with the clinical judgment. And with this news and news which are being used by the staff nurses to pick up the patients in the wards, I think they have a very good performance as compared to the Q SOFA. And using them without investigations, when the staff marks them and they always get alerted when the patient is moving from these colored charts, moving from the white to the yellow and this, so they become more alert. They are more aware that they need to see this patient more frequently and to inform about the deteriorating condition of the patient. So any tool we use, we must understand the limitations of each tool. Q SOFA has been good to alert us about the possibility of sepsis, not standalone, rightly as been pointed out by the guidelines, along with clinical judgment. Now, recently there had been a paper that an AI algorithm based on the Q SOFA was able to decrease the mortality. So we must know the limitations of the screening tool which we are using at what point and what for purpose.
Perfect, ma'am. 2 words, no tool is perfect. Your clinical judgment has to be there. Q SOFA was missing many, and probably other tools which we use as a routine in our ICU hospital out of the ICU and use the clinical judgment and all of these scores which don't have a lab diagnostics. That's what interesting I found. So all the MUOS, NEOS or Curve 65 kind of scores, these don't have a lab. So we don't rely, and this can be applicable across the length and breadth of the infrastructures, even in the resource limited setups. But again, as you re-emphasized, Q SOFA has been in use, which actually gives you a sicker group of patient. When you have a patient with sepsis, suspected sepsis, and Q SOFA being positive, pressures are low, tachycardic, all that is group and altered in sensorium, they have a higher mortality. They need a more attention. That group being needing a special attention. So as you said, somebody also adding that to existing other screening tools probably have a better maybe attention to those patients. So Dr. Pyle, we do a regular probably clinical audits in our departments and being a part of many accreditations, either you take it national accreditation or international accreditations and ICU quality markers. So this time we actually come across with a sepsis care or a sepsis management being a part of your quality assessment by different measures. Honestly, I will probably take a few seconds to tell when we actually did an audit of our own hospital ICU septic patient, where we had a protocol of bundle of an hour. Our average time to actually deliver antibiotic was never an hour. It was more than that in average time. And we realized 6-7 years back when we audited that this is the real story. The reason are many. So what do you think when this guideline came up with a concept of doing a quality indicator or a quality assessment? Dr. Pyle.
Yes, sir. So this in the survival sepsis campaign guidelines of 2026, there had been a core physiology shift. And this philosophical shift from bundle compliance to meaningful care delivery is definitely a welcome move. So, if we consider the key QI domains which are being highlighted in this recent guidelines, they include the following, like the early recognition system, antibiotic stewardship with timeliness, which balances early antibiotic versus right appropriate antibiotic. Next is fluid hemodynamic optimization, where the QI has shifted from the volume delivered to the response achieved by monitoring the fluid balance and avoidance of fluid overload. Because as Dr. Aditya had rightly emphasized, for the first time, de-resuscitation or active fluid removal have been emphasized in these recent guidelines. Next QI, which was highlighted, was definitely early usage of vasopressor, encouraging protocols for peripheral vasopressor administration. Next was the serial lactate measurement combined with capillary refill time assessment and urine output monitoring. Next, the QI which was emphasized upon was the time to source control, which had come down to less than 6 hours. Team-based sepsis pathways, the multidisciplinary involvement in management of a septic patient with the involvement of the emergency department, ICU, microbiology, the nursing team. So next thing, the next QI domain which was emphasized was auditing, continuous audit cycles, benchmarking, feedback, and data system. So with the core principle being what gets measured gets improved. And also what else was emphasized was education, training, and post-sepsis care. However, QI in sepsis is no longer about ticking the bundles. It's about delivering the right care at the right time for the right patient. Now, let us come to the key barriers which we face day in and day out while implementation of these QI domains. First is the resource variability. Definitely, the lab access and manpower is not equitable and equigenously distributed in all the units, particularly during the off hours. And this can definitely affect the completion of the bundled approach to septic care. Documentation fatigue. If we have over complex protocols, then these protocols will definitely be mere checklist and they will never translate into practical purpose. And this will definitely lead to reduced compliance at the bedside. Heterogeneous training level is also very, very important because frequently what we find is staff attrition. And this staff turnover in a frequent manner necessitates repeated training and retraining and reorientation. So that definitely leads to a problem in implementation of these QI domains. Now coming to the adaptations in a pragmatic manner in a resource limited setting. Instead of complex course, we are using the modified early warning signs and clinical signs and symptoms. Now, prioritization approach strategy, that is antibiotic first, when full bundle compliance is not immediately visible. This has also been emphasized upon. Training paramedical staffs are equally important for early steps, like in case of IV access creation or sampling. Now, key takeaway of QI in sepsis is not about rigid protocolization, but we need to adapt this in a contextual manner. We need to balance the evidence-based care as per the practicality and the feasibility of the unit where we work upon. Because as you know, most successful initiatives are when we keep it simple, safe, and team-driven rather than solely dependent upon guidelines, bundled approach, and checklists.
Yeah, perfectly, ma'am. I think you cracked it right. You mean to say that it should be adaptable, it should be practically possible in that particular unit, and they should have a way to audit and probably do a quality assessment of the management. So we're going back to Dr. Ritu. Dr. Ritu, we had so many codes from our medical school days, code blue, and recently we came across code stroke has been a common phenomenon for the last decade and a half. And so sepsis is an equally important killer in our ICUs and more so in the medical areas and all. But this was not formally been any time yet. Many of our institutions were using it. So what is your take on how code sepsis will change the game? Is a time is a tissue, time is a organ. How will it change?
Good evening to everybody. And so I'll be first talking, before answering the question, I'll try to trace out what 2021 said, what CDC says, and then we'll be coming to what 2026 guidelines says. So in 2021, also there was some mention about some screening or standard operating procedures to detect sepsis. A proper term of code sepsis or sepsis huddle was not defined, but they had mentioned something. Then CDC also, the recent guidelines said that there has to be a specific dedicated sepsis coordinator, which can enhance the accountability, multi-professional expertise, and that sepsis coordinator will improve the effectiveness of screening of sepsis. So I think by getting this sepsis code in 2026, it is more of a quality indicator because it tries to set parameters for maybe the nursing staff, maybe the junior doctors, and definitely it is a welcome move. And probably in this 2026 guideline, it has just emphasized about passive protocolization towards multidisciplinary sepsis activation. It has still not said whether every hospital should have it as a mandate. So for me, I think it's a quality indicator, and it should be, we all should welcome it as a good quality
We
indicator.
also try to initiate if feasible in your unit as a
Yeah.
sepsis code, and I think most of the times it starts with emergency. So the
Yes.
acute care team, including emergency nursing team, emergency paramedical team, emergency doctors should start it, and it carried in a continuation to the ICU as we talk about first hour of antimicrobials, vasopressor initiation lines and all. So it will give a continuity and a uniformity of
Yes.
things. So coming to Himaldev, there's a lot of the similar way pre-hospital assessment, pre-hospital antimicrobial has been talked about in this particular guidelines. What is your take on pre-hospital assessment in context of countries like us?
Yeah. So Dr. Venkat, Dr. Gunjan has already, she has highlighted upon these early warning scores, as you rightly said, what has been used. So the guidelines also recommends use a screening tool, pre-hospital screening tool, but they don't clearly say which one to be used. So the ones which are commonly are what we summarize News 2, Muse, and QSOF and SIRS. But if you look at the data, the studies showed that News 2 had a better absolute test performance compared to QSOFA. And but the panel refrained from recommending a particular tool because there's a lot of high false positive rate. As you said, even a patient with a non-septic guy can fall into that, and you can falsely diagnose them as sepsis. So these hospital screening tools has to be carefully selected. Probably News 2 would be a good scoring systems. But if you look at the Indian scenarios,
Himaldev, I just wanted to, we had a discussion on the screening tools.
Yeah.
No worries on that. But the whole discussion to you is pre-hospital, that is in the ambulance. That is when the medical team reaches to a peripheral area and then recognizes it, looks like a sepsis, like we possible, probable, or a definite sepsis, and taking a call on that. So what is you think, even including antimicrobial? I wanted you to, if as you said, some screening tool has been used, probably News 2, but how do you take that? Should this be a practice? Should this be and pros and cons
Understood.
about it?
Understood what you're trying to ask. So in our setup, probably it is very difficult because there's a lot of fragmentation, in the
Yeah.
emergency medical services.
Yes.
The ambulance services are a little different. The training level of these paramedical people who are going there, sometimes if doctors are not there, don't know exactly how are their assessment status. And there is no standardized triage culture. And sometimes there can be a late presentation and there can be undifferentiated shock. It cannot be a sepsis, it can be other kinds of shock. So these are the probable reasons where these pre-hospital screening tools may not be very effective in these populations.
Perfectly agreed. I think the awareness, the intellectuals, the knowledge levels, and the uniformity in the practice of the ambulances and transport services has not reached to that layer. But my contention to you will be we're talking about a pre-hospital ambulance thrombolytics.
Yeah.
So I feel antimicrobials are not that kind of a highly, what you can say, high alert medication compared to a thrombolytic agent. But yes, I agree. Before we go to that, jump to that, which will also load us with a lot of antimicrobial misuse. So we need to maybe, as you said, need an effort to teach, train these all kind of scoring systems and may bring some light to them. So that probably will help.
Yeah.
So we will come back to you for few more questions. Back to Gunchan ma'am. There are 2, 3 new words added. I always been a sepsis such a vague statement. Infection with organ dysfunction labeled as a dysregulated host response. But then many of the times you are not sure whether it is because of an infection, non-infection etiology. Sometimes we say probable this is a sepsis, possible this is a sepsis. This is definitely a sepsis. Then they say it doesn't look like a sepsis. But the words looks very, very subjective, probable, possible, likely, unlikely. How do you actually untangle them?
Rightly said, it is actually a jugglery of English words, with probable being slightly having a more positive chance than possible. And to differentiate a patient clinically without investigations is quite challenging. And this is similar to the previous when they said it is likely use antibiotics within 1 hour, and if it is possible, you can have 3 hours duration. So actually, when we say this, we just warrant to say that you need an immediate action, or that does not incline towards high intensity priority actions without the lab investigations. Because whenever it is likely or possible, probable, you need to reassess the patient again and again. You need some, because if you're waiting for lab investigations, they are going to take time. Organ dysfunction, defining organ dysfunction cannot solely be on the basis, even if you want to notice urine output declining, it will take some few hours. You want to get lab tests for creatinine, lactate to define that organ dysfunction, whether it is likely or possible, it is going to take time. So this possible, probable needs reassessment. The patient has basal, come with fever, you cough, he has a basal dullness, crepitations. The likelihood is highly, you put it in the probable category. The patient deteriorating over time, more tachycardia developing, desaturation, again it shifts from possible to probable. So that is just a jugglery of words. You need to reassess your patient. You need to see do an additional clinical examination just in spite on this, to see whether it is fitting into, you need an immediate action or you need to wait.
One question to you, ma'am. What do you mean by a definite sepsis? Is it just a culture positive, or I have a definite source? I know there is a pneumonia. I know there is a cellulitis. I know there is a pyelonephritis in my imaging. So will that be a definite sepsis, or we need a microbiological culture positivity to say it is a definite sepsis?
So microbiological culture positivity is going to take time. So when we say you do source control, you have a source, I think that will fall
That
into
should be a definite one.
Definite.
When I overlap of another possibility, like I'm overlapping with a pulmonary edema or a alveolar hemorrhage with a pneumonia, that's where the probable will come.
Yeah.
And unlikely chances will be a possible, and then
Possible.
later on we'll be saying looks like not a septic, but unlikely the other causes. But the message is, even though you put them onto the basket of sepsis, the moment you get into information that this is something else and it's not a sepsis, drop those antibiotic, drop those guns unnecessarily. Coming back to Dr. Ritu, what do you think the invasive and uninvasive game? So I have been listening to some of my senior colleagues in different institutions of India who have been not very comfortable to use non-invasive blood pressure monitoring for a low dose vasopressors. And some of us in our student days very bluntly used to say, probably it's not the way to go. But now surviving sepsis guidelines, it's fair enough. If you are on lower dose of vasopressors, NIV should be equally competent enough to give you a guidance. Dr. Ritu. Dr. Ritu, can unmute yourself.
Okay. So can we have the question again? There was some error from my...
IVP. So we were all discussing
Yeah.
where we had a situation where patient needed a vasopressor, we had a standard call to take a arterial line in place, invasive arterial line in place. And some of our senior colleagues and teachers used to talk about a moderate or a mild dose of vasopressors. NIVP should be a good and a moderate way to manage these cases. But we were not very convincing at that time. Surviving sepsis guidelines talks about it. What is your take on that?
Yeah. So, sir, as you rightly said, that NIBP can be a good choice for a low dose of vasopressor. But then we should understand also that what is the definition of a low dose of vasopressor? There is no uniform consistency on this low dose of vasopressor. Having said that, we should also be aware about the side or the, I would say, the limitations of NIBP. That it's about intermittent reading, it's reduced accuracy in vasoconstricted states. Otherwise, in hypotensive patients, it overestimates MAP. And if that kind of clinical judgment is there, especially in cases of growing obesity, poor reliability in tachyarrhythmias and obesity, obviously, yes, I agree that it can be a choice in low dose vasopressors. But in cases of occult shock, high shock, rising lactates, where you are risking an organ with respect to, I mean, I commonly give this example to my students that an IBP versus an AKI, what would you choose? So obviously, an IBP would be a better choice to choose than causing an AKI to this patient. So I think a good clinical judgment, yes, of course, you can do with an IBP, but but in very severe septic shock, organ failures, there rising lactates, tryptic shock, occult shock, obese patients, tachyarrhythmic patients, then definitely an invasive BP would be a preferred choice for me.
Yes.
Dr. Venkat, I just want to.
Yeah, please.
So I remember Dr. Joe's saying, a lot of we have seen practices where the clinicians, when the patient is in septic shock, trying to struggle to put an arterial and wasting a lot of time and not concentrating on the active resuscitation. So that's the idea. Probably that's where they have told that you can manage initially with NIBP, as rightly said.
Skill is also
Concentrate on
important.
the resuscitation, and
Right.
probably you can avoid AKI by concentrating on resuscitation. And
yes, right.
maybe later on, when you have enough time, you can do an art line. And not many hospitals still have an art line, even in the.
Yeah, skill is also important for an arterial line.
Yeah.
So I think a balance between a skill and the limitations of NIBP availability. Yes.
And
So
particular indication. See, as we know, a starting dose, and the moment you give a volume, the patient is recovering back to a normal MAP, normal systolic pressures. Probably you may not need a IBP.
IBP.
Rest of the times. But as you rightly pointed out, escalating doses of vasopressors, not picking up well the pleth, you're not sure about the readings, obese patients, difficult pulse, and probably a sicker group where you probably even peripheral line in the radial artery may not be enough. You may need a central access to.
Central.
Those are the extreme conditions which are absolute need of a invasive lines there. Himal, we'll come back to you. Dr. Pyle, there was a talk about not just complete the volume 30 ml per kilogram, then start a vasopressor, but in unstable patients where your pressures are not stable, start the vasopressor along with your volume resuscitation. What is your take on that? We have been all practicing that, but it came as a part of the new guidelines.
Yes. So 2026 guidelines actually shifted towards the early peripheral usage of vasopressors, and we actually find it more practical and evidence aligned. The real question is no longer is it safe, but as Dr. Ritu rightly pointed out, are we delaying life-saving therapy by waiting for the insertion of arterial line or a central line? So that is the $1,000,000 question. So why early vasopressors matter? Hypotension duration is directly linked to worse outcomes. Time is tissue. So if we are wasting valuable time, definitely we ourselves are contributing to organ hypoperfusion. Early norepinephrine helps in restoring the vascular tone, reduces fluid overload, and may actually limit the positive fluid balance. And what has been stressed upon is positive cumulative fluid balance, that is CFB, or the cumulative fluid overload, does more harm than good to the patients. So, not fluid loading, but rather early emphasis on usage of vasopressors has been stressed upon in the recent guidelines. But at the same time, we need to balance whether the peripheral usage of the vasopressor may lead to extravasation and arterial ischemic injuries or not, or vascular ischemic injuries or not. Recent data shows that low rates of extravasation and most of the events are actually minor and reversible if they are recognized early. And definitely, skill technique is important. Risk is technique dependent. Basically, it is not dependent upon the routes of administration of the vasopressors. So, how to do it safely is the real game changer in these scenarios. Need to use a large bore cannula around 18 to 20 G in a proximal vein, preferably forearm or the antecubital area. Avoid the distal sites. Frequent site monitoring is important every 5 to 10 minutes initially. Limit the duration of the usage of the peripheral vasopressors, ideally to less than 6 hours prior to securing a central access. Basically, these are used for gaining time to resuscitate the patient. And keep antidote protocol ready. If some problem occurs, you immediately initiate usage of the antidotes. Now, what is the practical reality in our settings? There is definitely delay in central line placement. Why? Because of logistic reasons, because of feasibility issues. Sometimes to get the consent for central venous cannula takes a lot of time because of the financial aspects, because of the availability of the patient relatives at the late hours of the night. And also, there is definitely not equivalent amount of expertise or technical skill available in all the hospitals. Heterogeneously they are distributed as per technique, skill, or expertise of the doctors are considered. And definitely this practical reality needs to be taken into consideration. If we wait for central line insertion prior to initiation of the vasopressors, this will prolong hypotension, which is far more harmful than the risk of extravasation. So what's the bottom line? The fear of extravasation should not delay vasopressor initiation. Start peripherally, early and safely, and transition to central access at the earliest feasible opportunity.
Perfect. I think you balanced it well, both arterial line and central line. It's not that you will be chasing them, chase the resuscitation, use both peripheral lines for resuscitation early as possible. And when a patient needs and there is an indication, there is a lactate worsening, there is a rise in blood, the rise in vasopressor requirement, I think possibly these patients will need both of them. And sometimes we have a lot of resource limitations and challenges in logistics also. Dr. Ritu, there was an interesting comment. We have been gone through the role of steroids, and I don't want to discuss the old story of a hydrocortisone of 200 milligrams over 24 hours in an infusion or 8-hourly basis. But the point is fludrocortisone addition. The addition of fludrocortisone has been in multiple studies from my school days. I have seen that the mortality benefit has been shown in those particular studies where there is a fludrocortisone add-on. And this particular guidelines, there is a plus or minus of fludrocortisone first time. What is your take on fludrocortisone?
Fludrocortisone additionally adds some mineralocorticoid activity. And we've been studying this, as you rightly said, from the approaches trial, then from the adrenal trial. But for all practical purpose, even hydrocortisone also has got adequate intrinsic mineralocorticoid activity.
That was the debate all throughout.
Yeah, all throughout. Yeah. But the most important thing is the acceptance of fludrocortisone for through enterally. It is only available enterally. So yes, it can give some mineralocorticoid activity in patients who are in shock and can accept enterally. But what about those patients who are on high vasopressors? In those, we will not be able to give fludrocortisone. So I think the choice still in those patients of high vasopressors where enteral nutrition is still very doubtful about the absorption as well as the usage. So I think that there the choice still remains hydrocortisone in the usual doses. So practically, I don't think some much added benefit has been there for this. Neither there it is supported by any evidence also.
Selected cases, maybe there
Yeah,
is
selected cases of, again, low vasopressors.
Himal, coming back to you, methylene has been talked about length and breadth. many of us use in rescue situations, no standard literature evidence supporting its beneficial effect in mortality. But definitely we have seen vasopressor requirement have come down, hemodynamics are optimized. A lot of studies going on in India too with the randomization. What is your take on methylene blue?
Yeah, I think one of the panelists rightly pointed out. I think there was a discussion where many who have not used the methylene blue made a recommendation that it may not be beneficial. But there is insufficient evidence, as you rightly said, and definitely mortality is not a right measure. But vasopressor requirement definitely is brought down. But it is being used as a rescue strategy only in selective cases, but not in all the cases. In a case of refractory vasoplegic shock, either it can be sepsis or it can be a non-sepsis shock. Also, it has been used, but as a last rescue strategy. And if you look at it, there are certain problems with it. You know that in case of G6PD deficiency, they can go into a severe hemolysis. And in renal failure patients, most of our sepsis AKI patients are in renal failure. Again, there can be a problem there. And I've seen a lot of, sometimes a lot of extravasation which is being given in the peripheral line. There will be a bad necrosis of the arm also. So it has to be taken with a pinch of salt. But overall, not as a routine therapy, just like other vasopressors, but as a rescue strategy, may have a little bit of role, but it has to be individual basis.
Dr. Himal, you
I
triggered a
just want to ask.
controversy. We'll come back to you. Triggered a controversy in that same document. A couple of others has the same. Midodrine has the same kind of thing. Many clinicians said they use it. No evidence supporting it. In the same way, many of them who are using methylene blue, it's a consensus expert statement which said, yes, it was beneficial in hemodynamic stability. So what is your take on midodrine?
Again, so I'm not a big fan of midodrine, but again, I don't think there's an IV availability there. So it's an oral one.
Oral therapy. It's as
Again,
Dr. Aditya pointed out, when I'm triggering somewhere between 0.5 ml of norepinephrine, which is a very, very mild dose, the moment I drop, my pressure goes to 70. I start at 0.5 ml, my BP goes to 110. I don't know whether it's a dysautonomia. I don't know if it's some kind of a. The moment I start some amount of fludrocortisone and I play with midodrine, try to make the patient move out. The patient is sitting there, my primary consultant sitting on me asking, when are you going to sift the patient out? Is rock solid stable? But you are saying the pressures are dropping. So those are the few situations where we do use, yes, with those pinch of salt, without much strong evidences. And I'm glad that some practical aspects were brought to this sepsis surviving guidelines of 2026. Somebody was making a point.
I just wanted to ask your personal experience of using methylene blue, because I have used and never got a favorable result. So,
ma'am, we do use methylene blue as a therapy in the high vasopressor required states. So we had a mixed results. These are the patients who are extremely sick. To understand, as Dr. Himal said, we don't use at a first line. We use norepinephrine. You go to the highest dose, add vaso, and then edri. Then if none of them was helping me out, then only I go. And just imagine what is the percentage of those patients who survive without methylene or with methylene blue. Obviously, that will be very small. So just adding a methylene blue will not change the whole ecosystem of that particular patient. So, but ma'am, my personal experience being the methylene blue has helped in rescuing not less than 20 to 30% of patients from hemodynamic instability to a stable MAP of 65. Maintaining my lactates in some of those cases, but translating them into the mortality benefit was being always a question. So we had very few survivals on methylene blue who went home. And these are poisoning cases. These are vasoplegic states. These are cardioplegic states, post-cardiotomy states, and all this systemic inflammatory response and nitric oxide based something, rather than it is a purely a the protoplasm has gone up, you're in point of no return, and you give a magic drug like methylene blue and you think it will help. It won't help, ma'am. I don't think
that is what is the same experience. In some few patients who are not in severe sepsis, it has helped, but that is that in sepsis, our results were not encouraging, so not favoring the result. But rightly said, midodrine this is the place we also use midodrine, and okay, it helps in tapering off your vasopressors.
There was another controversy related to the blood pressure, ma'am. MAP 65. Then there was some studies came up saying 80 MAP or 70 MAP prevents AKI in elderly hypertensive patients. Further studies countered that, saying no, there is a high mortality because of increased dose requirement of vasopressors. And now we are talking about a little lower dose. 65 is no more the cutoff. It says there is a range of 5 or 10 to play around, and probably 60 to 65 is for elderly. What is your take on that?
I mean, practically, we have been practicing 65 to 70 in the practical terms, because 65 was the limit, and yes, you say it is a practical thing. We cannot exactly maintain 60, but lower risks the kidney, and so we are skeptical maintaining it actually because of the shift of the autoregulation curve. And rightly said, even our own guidelines, which have been published in the IJCCM, do recommend a higher target in the elderly, basically to maintain this autoregulation in the chronic hypertensive patients. So this raises a doubt that whether the higher dose, obviously it has enough evidence that it is going to create the higher dose for higher MAP is associated with complications, and is, on the other hand, there is no evidence that it will increase the long-term mortality. It will improve your mortality outcomes. So the result comes down to, you have to balance. It is a double-edged sword. Higher does not give us much evidence to maintain for higher days, but less the individualized this meta-analysis which has been done on the individual patient data. The authors themselves acknowledge in that guideline that their lower target may cause overall harm. So it should be taken with a pinch of salt, especially in those at high risk. So you need to individualize your patient.
Dr. Pyle, uh, part of fluids, not much discussion on 30 ml per kilogram. Okay, we will measure with the weight based, we'll individualize patients. Static variables are not been great, dynamic. And crystalloids, colloids, crystalloids, balanced salt solutions, albumin. How do you place albumin?
Albumin. So, albumin definitely should not be used as a blanket strategy for hypoproteinemia on presentation. So, it is a resuscitation adjunct basically, and it should never be a correction tool for nutrition. So, where does albumin stand? Basically, albumin stands in septic shock with ongoing high fluid requirement, which helps in limiting fluid overload. In patients with hypoalbuminemia with capillary leak and edema, it might somewhat contribute to improve the oncotic balance. In cirrhotic patients, hepatorenal physiology, there had been some clearer benefits of albumin. Post initial crystalloid resuscitation, when we are escalating fluids, but where it does not help, if isolated low albumin level is found, but the patient is without any hemodynamic instability. And also as a number correcting prevention. Sometimes we do find some of the doctors correcting or just chasing after the value of albumin. Albumin is 2.54. Please give albumin to this patient. But this is not actually the right approach. So what should be the practical takeaway? Use albumin as a hemodynamic tool in selected group of patients and not as a reflex response to low level of serum albumin.
Dr. Himal, continuing Dr. Payal, hypoalbuminemia, hypoproteinemia, anasarchic patient, logging fluid in third space, very common knee-jerk trigger from nephrocolics and intensive care colleagues. Infuse albumin, add 80 milligrams of furosemide to it. Oncotic pressure will build in the blood, and your hemodynamics will not get unstable, and you will put some ultrafiltrate out of your kidney. What is your take on that?
No, I don't believe in that. And see, in case if you have to remove the fluid, you don't have to infuse the albumin per se. So you can always, as long as the patient is stable and volume is adequately achieved and not in a resuscitation phase, then just a fluid removal, either the help of diuretics or with the help of renal replacement therapy,
Sometimes
ultrafiltrate.
To just add some spices to it, sometimes the argument is
Hypotension.
albumin hypotension is one, yes.
Yeah.
Second is the albumin used as a carrier molecule to your furosemide to the distal tubules and improving your filtration. So how do you address your arguments to hypotension and that?
You're putting a lot of googly there, yeah. So the diuretic resistance, one of the commonest reason is, as you rightly said, is hypoalbuminemia. So in that case, I'm not so sure whether it really helps, but if the patient is on a renal replacement therapy, then I would not give albumin and take the fluid out. Just go with the fluid removal through ultrafiltrate and not replaced unless the patient is a subset of a chronic liver disease patient with an AKI, or patient has a HRS component where the patient is recovering from the acute kidney injury. There's one subset of patients where I'll be pro albumin, but rest of the times routine use of albumin as a de-resuscitation will not be very feasible. I don't know what's your take on that.
Yeah, so I think, yes, we are all in that same phase. I agree. There is no concrete evidence supporting ki albumin plus furosemide is the way to go in all this anasarchic patient. The head-on comparison could not prove any head-on benefit there. It is all when sometimes you wanted some colloids to be given to build up some pressure in situations where you already given a lot of crystalloids and you don't have an option of giving further crystalloids, you give colloids, albumin as a colloid, and use furosemide for a different reason. It's not for that both, but sometimes when the patient got stuck with some focal edemas or anasarchic situations, these are all clinical practices which do happen, but as you rightly said, we don't have any standard supporting evidence that. But I will come back to other point. De-resuscitation, fluid removal has been added as a standard protocol. Earlier, we were all aware of it, but that has been put into a guideline. What is your take on that? How will you do it? How feasible it is? See, patient just got stabilized. What is the way? Will you use furosemide? Will you use boluses of furosemide? Will you use infusion? Will you use a filter? What do you do?
So I think this is a very good recommendation, recently added, and in clinical practice also I have seen a lot of usefulness for this de-resuscitation, especially when the lung is a concern, the fluid overloaded lung, and it should be always after the initial resuscitation phase, as you rightly said, in the later part. And main thing is 3 points has to align. One is the patient has to be hemodynamically stable, and your perfusion parameters like lactate and CRT should be okay. And we use our POCUS methods. You use your um, fluid responsiveness and see if there is no responsiveness there. And finally, look at the fluid tolerance also. Look at the B lines and fluorid B lines. There is worsening oxygenation, and there's a cumulative fluid balance which has been accumulating for many days. And use of excess scoring which shows a reversal there. Then definitely that's the point which will guide us clinically that this patient requires a de-resuscitation. And where you put an exact point whether to use diuretics or initiate a renal replacement therapy just for ultrafiltrate removal, that becomes a challenge. So the guidelines also, or the recommendations also says that use diuretics first. And if the diuretic non-responsive or naive, then probably that's when you consider renal replacement therapy and then take out the ultrafiltrate. But convincing the patient's family and the clinician becomes a challenge here. Just for fluid removal, putting a HD catheter and taking out becomes a lot of challenge. And they say the cost of the renal replacement therapy, the complications of the catheterization, many people will not agree, and there's a lot of hesitancy. But the only way to overcome is probably tell them that if you remove the fluids, you can wean them off the ventilator faster, reduce the number of days of ICU stay, and that's how we make up for the cost of it.
Absolutely.
But de-resuscitation is extremely helpful, Dr. Venkat. I think we
Absolutely.
practice it a lot.
I think I take your point. You are spot on. The data comes from that cumulative fluid balance has been independent marker of mortality.
Yeah.
So that's where. So uremia is an independent predictor of mortality. Cumulative fluid balance is an independent predictor of mortality. If my furosemide is not useful and refractory to that, and I need to be removed the fluid, then I need a way forward. And probably I will explain this complication. As you rightly said, all of us also been not in that aggressive proactiveness because we never had a okay furosemide diye hua nahi, wait karo. But if the patient is logged by 20 liters 30 liters by end of maybe a couple of weeks, you are locked there, the mortality will be high, you need to come out of it some or other way. The only challenge we find is patient's hemodynamics.
Yeah.
So in those situations, probably the slow CRRT kind of thing with slow filtration removal will be a choice, but that comes with a huge cost. So that's the limitations which we go through. I think we had a wonderful discussion. We had more than 150 audience. That is because of the elegant legacy panelist. I had Dr. Gunjan Paul, Dr. Pal, Dr. Himanshu, and Dr. Ritu. I think we had a wonderful time of learning, exchanging ideas, and I even never knew it was crossing an hour or so. with all of you. So any last take-home points which you probably wanted to add to this surviving sepsis guidelines, or you disagree with current surviving sepsis guidelines? Himaldev, any points?
Yeah. So I'll come to your point only about the pre-hospital administration of antibiotic in the first hour. They have given a very strong recommendation for that, but it becomes a challenge, Dr. Venkat. Suppose I'll give you an example. An ambulance go to a place and tries to retrieve a patient who has a pancreatitis and not sepsis,
Agree.
which mimics like a sepsis, and inadvertently they'll probably give an antibiotic, which antibiotic not so sure, and then the patient comes here and he diagnosed with pancreatitis, and he'll have a selective pressure on that antibiotic, and that's the end game. So in Indian scenario, it's little difficult, and probably that's where I would think we have to be very cautious before giving an antibiotic.
But I will still keep on telling you, the recent stroke guidelines talks about
Yep.
if a clinician in the ER or in ambulance gave a thrombolytic to a stroke mimic, and finally the patient supposed to, after an MRI, found to have a no stroke, he still can defend it was a stroke mimic. The rationale is the chances of these patients landing into bleed are much less than compared to the debilitating life they will carry. So I completely agree with you. We need to grow up. We need to probably put our team into that learning curvature. You put protocols, you make some difference. Yeah, some of the pancreatitis patient may get extra dose of antibiotics. Fair enough. How many of our genuine pancreatitis patients are not getting antibiotic in spite of so much of stress? But in the same time, one of my septic patient in a timeline may get an antibiotic for an hour. And they talked about if the duration is more than an hour, it's not 15 minutes, if not half an hour. If the duration is more than an hour, somebody is flying from somewhere, rescued from somewhere. Those are the situations. Dr. Ritu, you wanted to take a point.
Yes, sir. Regarding this only. So there was a discussion in the chat box also, which I was answering.
Yeah, there were a
So,
lot of
so
questions.
I feel that when we are discussing this as a surviving sepsis as a part of the American guideline, probably this is a big welcome that yes, the antibiotic should be given and should mimic the AHA stroke mimics. But considering in the Indian scenario, when there is an OTC over the counter usage of antibiotics, the question should not be whether it should be given or not. The question should be which antibiotic should be given in the ambulance, because then there is a lot of antibiotic use in the community already. And what it is a welcome move in America, probably because where there is very structured over the counter regulation that no antibiotics should be prescribed without a prescription. But here, to right center, people are using antibiotic. So, would you think that giving polymyxin would be a good choice in the ambulance? Because that's the antibiotics that should be given. So, I think that should be the answer,
Agreed.
greater concern for
Which
us.
antibiotic will be a more complex question than availability of antibiotic. Agreed.
Yes,
Dr.
that.
Any take-home points where you wanted to add into the surviving sepsis guideline, or you don't agree with the surviving sepsis guidelines?
This was the most controversial question is this only, the antibiotic. And I still do not agree with you that if we can give it to a stroke mimic, we can give it to the antibiotics also.
No, ma'am, I neither agree or
Yeah, I got your point.
trying
That
to make a
you were
point so
giving
that
a
we can
justification.
discuss.
I agree with you. But then there's so much of antibiotic resistance. It means we are giving liberty. So I will refrain from this.
Yes, ma'am. Thank you.
Yes.
It doesn't mean that the question which I created to
I
actually
agree.
make that controversy come forward, it's only to actually make the whole point.
I fully understand
Yeah.
that.
Dr.
Ma'am,
Pai.
and giving zone
Okay.
in a sick patient will not make any difference to a person who needs antibiotic for shock. I mean, I think, and that is the only antibiotic you would probably allow in an ambulance, I think.
Okay, well, Dr. Payal.
Yeah. So, what I felt was that with the emerging concept of artificial intelligence, possibly the next guideline would come up with some topic related with AI in sepsis and all those things. At this point of time, I would like to comment upon the fact that artificial intelligence in sepsis, when we fear that it's going to make us lose our jobs, it is not going to be so. Possibly, AI can act as an augmenter, not as a replacement of the clinicians. And definitely, AI utility in sepsis, we need to work on that because it will definitely shift the sepsis care from one guideline or one size fits all concept to a real time patient specific decision making. So, basically, what we need to do is be aware, be cautious of data fatigue, data sort of alert fatigue. That is wherein comes the role of the early warning scores. We should not get fatigued with the early warning scores, but at the same time, uh, AI can definitely help us in phenotyping of sepsis and also in antimicrobial stewardship. So AI in sepsis definitely is an arena which needs to be looked upon, and possibly this would be a welcome addition in the recent guidelines to come.
They mentioned about AI integration and also predictability and sepsis phenotyping, which I think has been mentioned in these guidelines, but there is no formal phenotyping or a proper clarity on that. Dr. Aditya,
Right.
you have been fantastic in bringing all those sepsis new guidelines and making our job easy. Any take-home points from you?
Nothing, sir. I mean, as clearly pointed out, that these current guidelines have given us a scope for practicing personalized medicine. I would like to put it that way, because almost 64% of statements are conditional recommendations, wherein they give us a scope to decide on a situational basis. So this is what I have realized after reading the guidelines, and definitely we hope that we get some more guidance in the upcoming guidelines.
Thank you, all of you. I hope all of us enjoyed it, and thank you
Very much.
Thank you.
all
Thank you.
Thank you.
Thank you, sir.
Himal
Thank
Dev.
you,
Thank you.
Gunjan ma'am, Dr. Ritu, Dr. Himal Dev, and Dr. Aditya, of course. It
All.
was a wonderful
Thank you.
discussion. Thank you, sir.
Thank you, Dr. Venkat. And Dr. Aditya, excellent summarization of the
Yes.
entire big topic. Very nicely done.
You are all
Yeah,
present.
of course.
Dr. Aditya's presentation made this very interesting. Thank you all.
Yes.
And I can.
Thank you, sir.
Thank you, Dr. Venkat.
Thank
Good
you.
evening.
Thank you.
Thank you.
Thank you,
Thank
sir.
you. Thank you all the
Good night.
panelists. Thank you.
Good night. Yeah.